We've got 4 presentations, and if we bring those presentations, which then gives a flavour of what the ARC is actually doing at the moment, then we can widen that into the sort of these are the challenges for the integrated care systems and boards. This is what the ARC, examples of what the ARC has been doing to try and meet those challenges from a research and implementation perspective, and how do we start to bring the two together, if that's all right with everyone. So, can I invite Michelle? Is Michelle here? Michelle Thirlwall, who's a musculoskeletal specialist physiotherapist in East Lancashire Hospital Trust and is an ARC North West Coast intern. And she's aiming to identify the main reasons why patients over the age of 60 who are at risk of falls continue or do not continue with their balance and strength exercises that are provided by the physiotherapists. Michelle.
Thank you. Thank you for inviting me today, Ron. Lovely to meet you. I'm a little bit nervous. So it's the first time I've had a big public speaking like this, so just bear with me.
If I can do it, you can.
Right, everyone can hear me all right, lovely. So lovely to meet you, yes. My name is Michelle Thirlwall. I'm a musculoskeletal specialist physio based at East Lancashire Hospitals, NHS Trust. And we're looking today, I'm chatting about MSK, health inequalities, and what our service is doing to help address some of these at the moment. Okay, so at the moment, you're quite right, I was an intern with NIHR ARC that ended in March, and now I am doing a research scholarship, so fortunately to carry on with the research work that I'm doing, and that's with NIHR CRN at the moment. Okay, next slide, please. Can I move that along? Thank you. So a bit of quick chat about what I'm going to go through with you today. So I'm looking at just a quick intro and looking at health inequalities specifically to my area in East Lancashire. A quick chat about my research project, but the poster is actually at the back if you want to look at that in more depth. And then 2 other research projects that are going on in our service, just to represent that a little bit as well. So next slide, please. So I've been an MSK physio for 15 years, and just similar to what's been said, I think looking at things into a bit more depth has always been an interest of mine. And following a public health module, which brought to my attention the theories of asset-based approach, social marketing, and the fact that we have this knowledge, are we getting patients to change their behaviour with it, is what led me to look at the gap that my research is in. And so my personal aims at the moment is continue with my research as a principal investigator. I'm currently about to go through ethics. And then reduce health inequalities, try and improve patient care by doing so, and then promoting and embedding research in ELHT, specifically with AHPs, so allied health professionals. We don't have a high representation of research in AHPs, as you know, in the Northwest, so it's looking at improving that and promoting the work we're doing a bit more. Next slide, please. Okay, so East Lancs, we obviously we've gone through about health inequalities, haven't we? And they are avoidable, and it's in the unfair differences in health status between groups of people and communities, and it's looking at bridging that gap a little bit to healthcare access, and obviously ensuring safe, personal and effective care. So East Lanc area, it's a high levels of high deprivation. There was a map on the previous slide, so I should have gone through the area then with you, but it covers Pendle, Burnley, Blackburn, Darwin, Rosendale, quite a large area that we cover and a very diverse population. So how can we as physiotherapists or as a trust match or try and meet the needs of all these different people with different backgrounds? So it's a lot of non-English speakers. We obviously have an ageing population like other areas here in the Northwest, and levels of low educational or IT literacy. And I think a little bit, just going off tangent slightly, looking at the long-term plan that the government have discussed in terms of bringing into NHS policy, wanting to use more IT, and obviously looking at our population and how we can meet the needs of their literacy needs as well. Okay, next slide, please. Okay, so how are we in MSK Research reducing health inequalities? So as I said before, we're bridging the gap in healthcare access and utilisation, so trying to improve the outcomes of our patients in the best way we can. So all 3 of our research projects, we're recruiting from a wide range of people as best we can for the interviews. We have PPI groups, so we all have different ways of engaging with those. I've got 2 public health advisors, and we're looking at community engagement events, looking at the DNAs, looking at those who attend our services and looking at those who do not. And looking at obviously use the HIAT tool to help map those priorities, and looking at what we do with the results afterwards, how we can improve equalities with what we've found. Next slide, please. Okay, so my study, just a little bit of a background. There's a lot of words on here, so I'm not going to go through it all with you. But as I said, my poster is at the back if you want to go specifically into more depth. So essentially what I'm looking at is the barriers and facilitators to exercise engagement in people over 60 at risk of falls. And a bit of the background is that obviously we have a high rate of our ageing population, and 1 in 3 over 65 and 1 in 2 over 80 are likely to have a fall in the next year, which is a massive cost to the NHS of 2.3 billion. This is linked in with a high rate in our area of hip fractures, people presenting to A&E following a fall. So we obviously want to try and reduce the amount of hip fractures and other injuries of people experiencing the falls. And obviously it's been highlighted nationally as a priority, which is frailty. And why it's relevant to our service, so in musculoskeletal physio, we receive a lot of people coming through who have had a fall or have had an injury, and this isn't just hip fractures, this is soft tissue injuries. It could be an ankle sprain, or it could be something like a shoulder muscle tear, or it could be a shoulder fracture. And so what we're looking at is, instead of reacting to, we tend to treat the problem that they're in with, looking at it from a more wider perspective, is what do we do with that person who is recurring, who is falling more? Is there something that we can do to improve or develop more pathways to manage these patients better? And obviously following COVID, what services do actually exist? So it's bringing together our trust and communication with different services a bit more. So every health professional should also be screening for the risk of falls, and it's looking at implementing that too. And obviously as physios, I'm carrying out interviews with my patients who are classed as risk of falls. We know that exercises help reduce the risk of falls by about 24%, 35% if you add on resistance work. It's not the only risk of falls or the only thing to help improve fall management, but it's something that certainly is something that will help improve strength and balance. And we know that 78% of patients are not doing this, as a study in Australia. So why is that? Why are patients not exercising? And I guess looking at, is it a staff communication thing? So is it the fact that they don't know to carry on with the exercises? Is it an understanding of what they've been given, either exercise or resource-wise? Leaflets, IT provision, are we meeting their needs in how we need them to engage more? Or is it more society-led? Is it the fact, looking at, obviously we talked about ageism, do patients, and I'm not saying that a 60, 65-year-old is unfit necessarily. Obviously, as they get older, you might have a very fit 80-year-old who isn't a risk of fall, so I'm not looking at ageism and putting people in categories, but obviously as people get a bit older, do they think, oh, actually I don't need to do that? What are the priorities there? Next slide, please. So that's just a short post. I didn't actually realise it was going to be up today, so that's really good. You can have a little look, which gives a bit more of a detailed look at questions that I'm asking specifically and a bit of the background. How reducing health inequality is a bit more specific. Obviously, use of the PPI groups, they've looked at my patient documentation, which includes the interview schedule, includes the protocol, the consent form, the patient information sheet. So I've had opinions on that. I work quite closely with those members. The interviews and questions themselves are asking patient opinions, so looking at their thoughts on it specifically, and then looking at the results, whether we need to tweak what we're doing. So I've had to introduce a new template into our service to see, which is undergoing a pilot, to see if what are staff doing at the moment, evaluating it, and we've can we get a prevalence at least of what is coming through our service? And so the outcome, there's lots of outcomes, short term, medium term and long term, but essentially we're looking at improving those, the material we give, the quality of care that we give. Do we need to change that in any way to meet the needs of these patients? Do we need to combine efforts with looking at frailty and falls pathway across the rest of the trust, which is happening at the moment as a newer thing, and just basically improving the safety of our patients and their long-term health and physical and mental well-being. Next slide, please. Thank you. So this is next slide. So looking at the MSK Research, the two other studies, just quickly going into those with two of my colleagues. So as a promotion point of view, one of them is called Matt Kenyon, and he's an MSK extended scope practitioner, and he is looking at Achilles tendinopathy. So specifically looking at what's called continuation, looking at the exercise that we give for these patients, that most of the research is based on athletes, not on general patients from population. So looking at interviewing again these patients from a diverse background to see if their needs differ and what physios can do about it to change our management. He's also an NIHR scholar. Okay, moving on to the next one. And then we've just got Pauline Mace. This is my last slide. So Pauline is doing interviews as well on shoulder fractures. So again, looking at the information that we give to patients following a fracture and what their thoughts are on this information, whether we need to look at giving it a different time, or any thoughts around the management of those patients. Okay, thank you.
Any questions on Paul? Because we haven't got enough room for everybody to stay sitting up here. So any question on Pauline's presentations before I move on to the next one?
It's Michelle.
Michelle? Well, you just had somebody called Pauline on there. Sorry, Michelle.
Pauline's my colleague.
Yes, I know.
I'm just promoting her research.
Sorry, I haven't got. Sorry, my mistake. Sorry, apologies.
Yeah.
I actually don't. I had to write the names down on the presenters. It's not on my sheets. So, Michelle, got a couple of questions, then we'll move on. So, just introduce yourself before you...
Hi, Michelle. Hi, everybody. I'm Alison Doty. I'm from the ARC, the MIDAS team. I'm very interested in your research because I'm doing some research myself on falls, risk factors and falls preventions for people with intellectual disabilities. One of the things that our research has brought out is that people with intellectual disabilities are at risk of falls at a much earlier age than the general population. I'm talking from 40 onwards. I was just wondering whether your service is accessible for people with intellectual disabilities from an earlier age. Thank you.
So I guess the two parts of that is the intellectual learning disabilities. We do have referrals from patients that do have learning disabilities into our service. But if I think of my caseload, the referrals, we don't get an awful lot. So whether they are supported in a different service or whether they are not communicating enough their needs, that does need to be addressed. Because if I think of our population, obviously we do have patients who may struggle to communicate, whether that is hearing or a learning need. But in terms of a identified learning disability, we're not always aware of those patients coming through. I
can feel a rapid evidence synthesis coming on to answer that question about what we know about how to support people with learning disabilities who are having falls and how services need to adapt. So hold that thought, because that's potentially useful at perhaps in September when we have our races session. You could talk to the MIDAS team about maybe pulling together a question and coming along to that to do a rapid evidence synthesis on the day, which is something that we'll be offering at alternate ARCFEST.
A lot of patients, the research on falls is over the age of 60. It's not looked at from a younger population. We know that it does happen, but obviously it's looking at the risk of falls criteria and why that's happening in the first place, and that's why it's over the age of 60. 65,
so we'll pick that up with you later on and see if there's something we can pull together around that. And if anyone else is interested in that from any of the other member organisations, please do talk to Michelle. You could talk to Pauline, but she's not here. Sorry about that, Michelle. And
all right.
one other question. Just introduce yourself if you don't mind.
Michelle, I'm from East Lancashire as well. I'm a CD in Rosendale West area. Thank you. We did some work with the excess winter deaths a few years ago in our locality, and one thing we found was that some of the determinants of excess death was related to socioeconomic background of our residents. Did you find that in your data, that falls were higher amongst the lower socioeconomic households?
So, again, a lot of our falls data is, well, there's on fingertips where we can access the rates of people going into hospital. We can access the rates of hip fractures, but we don't have, like anything else, I don't think we have a lot of systems or data that supports the prevalence of patients coming through. So it's something that I've tried to set up about a year ago with a template just into our service in Rosendale, actually, of what patients are coming through, and based on the early data, which I've yet to fully appraise over the last year, but based on that, there seems to be the ones filling in the form tend to be over the age of 70, 75, as opposed to younger, which is just Rosendale area, bear in mind. More females, more females coming through. But all of this, looking at the prevalence, has been a bit of a problem because a lot of our data is come through these are physios that are picking up the patients coming through and accessing, because as a referral point of view, they're not referred in with this patient's had a fall, they're referred in with an injury or a problem. And so it's not until the patients come in that we actually then can work out which of these have had a fall. So it's looking at the pathway from quite an earlier stage to identify the prevalence more accurately, but rather than based on clinicians filling something in. There is new pathways being set up currently that some of the community members of the team have started to implement. So, and that includes looking at more of a more quantitative way of recording a frailty, which is like the electronic frailty index and the clinical frailty score. So these are things that we need to sort of embed a bit more and look at exactly how can we identify these patients at risk. So what did start off with me thinking was a problem here, we're not picking them up, we're not moving on, we don't know what's available, turned into looking at pathways as well as looking at the exercise provision and management plan. And I think it will come together. It's just how do we tailor it to, like you said, those patients who are from a low socioeconomic status, as well as those who have more higher academic awareness. So.
Okay, I'm just anxious about time. So, very quick question, and then we need to move on if you don't mind. Thanks.
Thanks very much. My name's Rob McDonald. I'm a ARC public advisor with a complex series of conditions. One of the most positive things I experience is water therapy and ARCFEST. And every Friday at 12 o'clock, I go for a 1-hour session with about 80 ladies and one or two gentlemen. And I'm one of the one or two. And we dance to ABBA, to the Beatles, to Pet Shop Boys. I just wonder how much ARCFEST goes on in the region. Thank you.
So I think a lot of what you're asking there is based on the links with our community sort of services. And I think this is another sort of bit of a health inequality, because across the patch, there is a very different level of funding that goes on in terms of Blackburn with Darwin, Pendle, and say Rosendale. So although I'm based at Rosendale and the pilot has and research is in Rosendale currently, I would say that the links there is less, perhaps a bit less available than maybe in the areas where there is slightly higher risk of deprivation, and where there's more funding to linking with the community services. Following COVID, I think it put a bit of a spanner in the developments that had gone on, because obviously leisure services ceased. So our referrals and what was available stopped, both looking from a public and a private sector in terms of leisure. In the NHS, we don't offer a hydro aquafit sort of exercise. We do have, in MSK Physio, we do have what we call a SCAPE, which is an Oxford-led hip and knee OA and spine OA treatment. So they have a few sessions in a gym with us, education. Some of that is long-term management of exercise. So we do offer classes and group classes, but we don't have that in the NHS. So it's looking at linking better with our community providers to offer that sort of thing. But it's interesting how you obviously said, you know, there's 2 men
Okay.
and a lot of women. So
Thank you very much indeed. So thank you, Michelle.
Thank you.
Comments on the chat. I can see, I may have missed some earlier, but yes, we shouldn't be waiting until we get to 60 before we exercise. So the next presentation is from Temitayo Roberts, and this is pre-recorded. I don't think Temitayo is online, but if she is, we can maybe do some questions online, but otherwise, is Temitayo's presentation available?
Hi, my name is Temitayo Roberts. I am a registered and qualified psychological wellbeing practitioner with the British Psychological Society and also a transformation manager with the Cheshire and Merseyside Integrated Care Board, Warrington Place Primary Care Team. Today, I'm going to be presenting on improving access to psychological therapy for stroke survivors. It's a small part of the ADOPT study that I took part in here as a research intern in UCLan. I just want to give a quick background. Psychological problems following a stroke are common. So for example, depression affects about 1/3 of patients following a stroke. Anxiety affects 1 in 4, and post-traumatic stress disorder about 10%. They are important as they affect the recovery that patients make following their stroke. Patients who are depressed are less likely to participate in social activities and report poorer quality of life. Despite being associated with significant morbidity and mortality, they frequently go undiagnosed and psychological care after stroke is limited, with 65% not receiving the psychological support needed. Because of the problems that people have after a stroke, there may be some health inequalities associated with accessing services. So patients with communication problems may not access IAP services. They might have mobility issues in getting to clinics, difficulty expressing themselves due to speech problems, and cognitive problems impacting on memory to be able to remember therapy appointments. The majority of services have looked at other long-term conditions such as cardiovascular disease, diabetes, respiratory, and chronic pain. Only a few services looked at stroke, and this was not even included in the early implementer site or the 5-year forward plan view, which are also health inequalities in themselves. The ADOPT study tried to look at how feasible to deliver collaborative psychological care after stroke within the NHS, the voluntary sector, including Stroke Association and the now called NHS Talking Therapies, which was known as IAPT, and within the primary care. This was done in 3 phases in order to identify gaps within services and develop a better psychological care pathway. And you can see that under the phase 3, which is the evaluation of the implementation of this. So the care pathway was done across 4 sites, and it looked at providing collaborative pathway training to staff, so psychological training to stroke-specific staff, and then stroke training to mental health staff. And there was the ADOPT training and the manual as well, and supervision to be more tailored towards stroke and stroke patients. So the aim of this research is to explore IAPT staff perceptions and experiences of supporting clients following stroke. I interviewed 6 members of staff, including psychological wellbeing practitioners, cognitive behavior therapists, counselors, and using the telephone, interviews were transcribed verbatim, and it was analyzed using content analysis. And I did the initial coding, and there was a second researcher who did the second coding to check for trustworthiness and reliability. So in terms of what we found out, the results, they were positive in terms of many staff members liked the fact that the training raised their awareness and increased their knowledge of how to adapt their session and accommodate stroke survivors as their patients. and it gave them more confidence, and also being able to be proactive to link up with stroke-specific teams, and the stroke-specific teams being able to link up with psychological therapy teams. However, there are still significant constraints in terms of the way IAPT, or national, NHS talking therapies, is set up, and which includes the standard measures and the way that things are done, which are not really linked with stroke-specific services. So in terms of lack of specialized knowledge and experience as well, and the way the IAPT was set up in itself were barriers. So we can see that under the health inequalities on this slide, because we've already alluded to it in the previous slide in terms of a few health inequalities issues that have been mentioned earlier on. However, COVID also came along, which affected and impacted even much more the barriers that people who've had stroke were having to access services. And a few of the things that were highlighted by the stroke clients, I was able to capture this by completing a public people involvement study with them. And one of the things that they said was not being able to see the person's behavior on how they come across face to face, make them feel concerned that things could have been missed, whether during the assessment or in order to support them in the right way. And some said they prefer video calls, but at the same time, they prefer that face-to-face would be the best way. And some do say they like the virtual call because they don't have to commute, because they rely on their carers to be able to support them in the session. So the carers can be working at home and be just on the side should they need help from them. And also that they don't have to physically go to a place and be waiting for a few minutes before being seen. Okay, so these are just a few of the things that were highlighted. But in terms of what we concluded from what we found out, the staff members themselves, in terms of the conclusion, said being able to have the training and have better links help to improve, the way they deliver their therapy, and in a way, improved access for stroke survivors as their clients. And then when we spoke to the stroke survivors who are the clients, they said there are also areas of improvement that they can, that the service can improve on, which includes the therapist speaking slowly to help them process information, because speaking fast can make them dizzy, and having shorter sessions. So if they're doing it over the video call, they're not looking at the screen for too long because that makes them tired. And giving enough time, to process things, again, came out again and again. And also being able to talk through their homework rather than having to write it down because they find writing difficult, and getting help during the session to actually complete their standard measures was also one of the things highlighted. Thank you very much for listening, and I welcome your questions, and we'll get the answers to you as soon as possible. Thank you.
Thanks very much. So if you have any questions, please put them in the chat and we can transmit them through to Michelle. And because Michelle, are you here live? No. Sorry. Temitayo, sorry. I must stop looking at my handwritten notes. Temitayo, you are here live. See, I wasn't expecting that. I was told this was a recording.
Yeah, sorry about that, because I've got a meeting right here in work at 11:30.
Sorry.
I wasn't able to compute that.
I hadn't realised, so I thought it was just a recording. So you are here, that was delivered live, and you are here. Right. So, we haven't got very much time, so if you have any questions for Temitayo, please. Alison.
I just wondered whether Temi can talk a little bit more about the ongoing work that she's got planned. So she had another internship after the Clark and is looking at developing a fellowship.
So you've been prompted here, Temitayo.
And whether there was something she wanted to discuss about health inequalities within
So this is a strong poke from Alison to talk about the work that you're now doing in your second internship. Very briefly, if you could just sort of introduce us to what you're now doing.
All right, so briefly, I'm looking at a systematic review of the barriers and facilitators of remote psychological therapy for stroke survivors, because when COVID happened, we found that obviously there were issues around being able to support stroke clients in a way that is equal to people who've not had stroke, which is another health inequalities issue in itself. So yeah, that's where the PPI work came into being, in order to be able to find out from them how best we can ensure that we mitigate against those health inequalities and still be able to deliver remote psychological therapy should, you know, a case like COVID happen again, or how we can, you know, adapt our therapy sections following what we've learned from the adult training, and in terms of all the barriers that we might have if we cannot deliver it face to face. Yeah, so that's where I am up to in terms of speaking with the stroke survivors themselves, and also working with the Northwest Research Design Service in order to ensure that all the necessary ethics and information is all, you know, compiled within the systematic review. So I'm doing like a races and just checking that all the literature review that's been done around the remote psychological therapy is also taken into consideration.
Great. So thanks very much, and apologies for the confusion. I thought that was a pre-recording. So nice to see you here in person, remotely. And there's quite a bit of work happening in the person-centred complex care theme about remote consultations in primary care. So if you haven't linked up with Jenny and colleagues in PCC, please do, because it'd be useful to compare notes perhaps on the work that from that project, which myself and many others are involved in. And second plug for races, well done. We'll keep doing it, Andy, we'll keep plugging away. Any more, or can I move on to Ben? I'm going to move on to Ben, I think, in view of the time. Thank you very much, Temu. There's a comment on the chat here, just while Ben's getting ready, about young stroke survivors. Absolutely. I don't know what we mean by major plans. I'm assuming that services are adapting for different age groups, but we could certainly, that's a discussion to bring, perhaps. So, Ben.
Thanks, Mark, and well done for getting my name right.
You're welcome to do this any time you like, you know. It's easy to sit down there and carp.
Sorry.
It's like you know, it's not football. It's not. How did he miss that? How did he miss that easy header?
Ben Barr, I'm Professor in Public Health at the University of Liverpool, and I lead one of the themes in the ARC, as Marcus said, the Improving Population Health theme. So I'm just going to talk briefly about one of the projects that we've had coming out of the theme, and you know, appropriately, this is a success story, really, and a success story in terms of the kinds of actions that we've been talking about, that Greg mentioned about. You know, to address health inequalities, we really need to address the economy and the sort of economic inequalities and the conditions in which people live and work. So this is a study that is appropriately about Preston, this great city we're in today, and it's just recently been published in the Lancet. And we basically look at the impact of Preston's sort of local economic strategy on mental health and well-being. So, for those who don't know, Preston implemented a kind of innovative approach to its own sort of economic strategy, looking at how it can help influence the local economy in a way that promotes better kind of equity and also sort of health and well-being. And there are a number of sort of components to this strategy, sometimes called community wealth building, also sometimes known as the Preston Model. But there's a number of components to it. And they started this work around 2014-15, and this was during a period where, you know, there's austerity. So Preston was facing large cuts from central government grants to the local authority in particular, but general sort of cuts in services. And their approach was to look at kind of what sort of wealth and assets do we have within Preston, in particular looking at the kind of big sort of public sector organisations like the council, the university, housing associations, and to some extent the NHS, and look at how are those organisations influencing the local economy? You know, when they're procuring in services, are they just going for the cheapest option, or are they looking at how those organisations are creating value for the local economy, but also looking at whether they're supporting good employment conditions and wages. So looking at what wealth is in the local economy, looking at how accountable those organisations and local businesses, the organisations that people are buying services from, are to the local population. So trying to promote developments such as cooperatives and other kind of third sector organisations, looking at the sort of working conditions, so introducing things like living wage policies, and looking at how they can sort of use sort of land and property that those organisations have for better social value. So one of the things that these big organisations did, we call them some anchor organisations, is to look at what services they are procuring from other businesses and organisations in the local economy, and how could they sort of buy more of those services from local businesses, or where there are gaps, how they could help develop local sort of social enterprises. So they did that across Lancashire to some extent, and in Preston, and did that in 2013. They kind of did a sort of audit of that, and then they looked at how they could change those procurement practices to spend more money in the local economy, up to sort of to 2017, where they assessed it again, and found that they'd managed to shift more than about 200 million from those organisations. More was basically being spent in the local economy, and with that also spending it in a way that could help promote that kind of social value. And there's some indication that had potentially led to an improvement in some of the sort of economic indicators in Preston compared to other places, but hadn't really been looked at systematically, and that was something that we looked at. So the sort of aim of the study was basically to look at whether those sort of economic improvements in Preston were sort of specific to Preston and greater than sort of other sort of similar areas, and whether that really translated to improvements in health and well-being. So we looked at a number of kind of sort of economic outcomes, so we looked at employment and wages, and then we look at a number of mental health and well-being outcomes. So the first one is this sort of index that combines measures from across a lot of different data sets, called the Small Area Mental Health Index that we developed. And we also looked at a range of other measures of mental health: depression, antidepressant prescribing, hospital attendances for mental health problems, and measures people's reported satisfaction with their lives. So obviously, to answer that question, we need to say what would have happened in Preston if they hadn't taken on this approach. So to do that, we compare Preston to a kind of control group, so of other areas that are basically selected to be similar to Preston and have similar trajectories up to 2015, and we look at this the impact from 2015 to 2019. So this is all before the pandemic, which obviously had kind of major impacts after that. So if we look at both wages and employment, we see that in Preston, after 2015, we do actually see much bigger improvement in wages compared to other places, and we also see some bigger improvements in increasing employment after this community wealth building initiative was sort of put in place. Not only do we see the improvements in wages overall across all levels of wage, but we also see that those improvements in wages in Preston were particularly at the lower end of the wage scale. So you basically had a much larger growth in the wages of people on low wages compared to people on high wages. So there was an increase in wages equivalent to about an additional £30 per week in people's pockets, but also a reduction in inequalities within Preston during that time. And you didn't just see growth across all of the economy, but the sector that grew the largest was the not-for-profit and mutual association. So that's basically the third sector. So the third sector grew in Preston by about 10% compared to other similar areas where there was basically no growth in the third sector. So see a reduction in inequalities and growth in the third sector. I'll move on because we're so short of time. And we do see an improvement in mental health and well-being in Preston relative to the comparison group, so compared to sort of similar areas. And we saw that in terms of this overall index of mental health that we developed. We also saw a reduction in antidepressant prescribing in Preston relative to other areas, and a reduction in diagnoses of depression in Preston compared to other areas. So some of these the effects are relatively small compared to some other initiatives, but that's equivalent to about 600 fewer people in Preston with depression compared to the control group. So, and we also see an improvement in people reporting that they were satisfied with their lives in Preston compared to other areas. So, all in all, we see that there is the study kind of demonstrates that there's the potential for, within a sort of relatively short period of time, sort of where there's concerted action across the whole system to try and address some of these economic inequalities that can have an impact on improving things like wages and employment, so there's kind of social determinants, and where that's, in particular, where that's also addressing inequalities in those social determinants, that does seem to have had an impact on improving mental health and well-being in Preston relative to other areas, but that does involve kind of concerted partnership across the whole system, and looking at not just about how can we make the services that those organisations provide more equitable, but looking at the total actions across those organisations. How do they influence the local economy? And for this, there is a particular role for the NHS. The NHS is going to be one of the biggest employers. The NHS and local government probably makes up about a quarter of the whole economy in a place like Preston. So there is a role for the NHS to maximise its impact, both in terms of its services, but also in terms of how it influences the whole economy. Thank you very much.
Thank you very much, Ben. Thanks very much, Ben. I'm slightly anxious about time. Really interesting presentation, and it's great to have something about Preston in Preston. And I think it's a really impressive demonstration of how the ARC can truly straddle what is an integrated care system and thinking about it. And I can see that Sakti's suitably impressed with the fact that we've been involved in that, and this is the sort of thing that we can pull together the data. And one of the things that Ben and his colleagues have spent an awful long time doing is getting high quality longitudinal data sets so that you really can start to drill down into the impact of large-scale initiatives or small-scale initiatives that are looking at health in much broader ways than, as you were saying, how do we change the service in the clinic. It's all important, but it's a network of different ways of tackling things from different directions. You can talk to Ben over the coffee and things. I'll just take one question, and then I'm going to take chair's privilege and squeeze a little bit on time because we have another presentation.
Just a quick one. Peter Lloyd. I'm a geographer by trade and a public advisor. I buy the overall thesis. I think I wish more people would buy it too. What I need to know just a tad more about, it won't take you a few minutes, is the whole methodology spins on the control group of other places. Could you tell us where they were?
So we use two different approaches to construct control groups. One was a set of local authorities, or basically other similar local authorities in the north that were similarly deprived, had similar levels of wages and employment. And another method that we used was actually based on small neighbourhoods, so hundreds of neighbourhoods across the north that had similar characteristics of as in Preston. So we use a set of local authorities. I can't remember exactly. There's about 10 or 15 of other local authorities that we use as part of that control group. But they're basically similar places of similar size to Preston that are similarly deprived and have similar kind of conditions, and all in the north.
We can talk about that over coffee, can't we?
We can go into the details later. Yeah.
So can I thank you very much, Ben.
Thank you.
So our last presentation before I come back to the panel for their thoughts on what they've heard is to ask Dr. Clarissa Giebel to come and talk about work that she's been doing in the older adult sub-theme in the health and care across the life course theme in the ARC. Oh.
Hello, I'm... Oh, good. Oh. Right, hi, my name's Clarissa Giebel. Some of you might know me, some of you might not. So it's nice to see so many people face to face as well. I'm a senior research fellow. I'm the older adult sub-theme lead within health and care across the life course. So unlike the other presentations, I'm going to give you a very brief snapshot of a couple of our projects that focus on inequalities in dementia, because we've got lots of stuff going on. Sadly, I can't mention all, but that'd be way too much. But we've got a lot of new postdocs coming to join us as well, and they're lovely here presented. We've got work going on music interventions, on hearing loss and dementia, and all of these different things, all underpinning inequalities in dementia care. So what happens after a diagnosis of dementia? So we have nearly 1 million people living with dementia in the UK, so this will hopefully help a little bit understanding, addressing and finding solutions to inequalities. So those are some of our key projects that are going on, PhDs, internships as well. I'm going to highlight a little bit one of our ongoing study looking at social care needs assessments and carers needs assessments. There's been very little research done to date, so we're trying to understand this a bit better, but also looking at the more global reach, how our ARC links in dementia inequalities research more globally on a European level and beyond. So talking about our social care needs assessment study, we've been funded by the University of Liverpool, and we're then going to apply for some subsequent funding as well, to understand the experiences of people living with dementia, the unpaid carers, of going through a needs assessment. How does this impact on you accessing care after your diagnosis? Does it actually help you based on your financial income, etc.? How is the process of these needs assessment done? Is it helpful? But we're also really interested in speaking to people to professionals who are actually doing those needs assessments. So local authority representatives, etc., who are delivering them. To date, we've spoken to 22 participants, not me, but James, our researcher, so he's done really well. 21 of them are people living with dementia and unpaid carers, and 1 local authority representative. The study is due to close at the end of next month, and we're really keen to hear from more professionals who are doing those needs assessments. So if you are one of those in the room, or if you know someone who is doing that, working at local authorities, would be fantastic to get in touch with us. So yeah, that's this piece of work. Looking at it a little bit more globally, what we're currently doing in the sub-theme, and yes, the ARC is Northwest Coast based, but we need to compare with other areas in England, but also beyond, to understand what's
What can we learn? Is it the same in Germany, in India, etc.? Is it the same inequalities? Can we learn something to improve care, for example, here in the Northwest Coast? Because there might be quite some similarities. So we've recently conducted a systematic review, what we called a BEAST, because it contained 39 papers from across the globe, and 23 countries were included. We wanted to understand what are the inequalities for people living with dementia anywhere across the globe in accessing care after the diagnosis. It was a lot of work to try and pull those through into themes, but we kind of found 5 key barriers. First of all, there were more barriers than facilitators to accessing care, unfortunately. And then we grouped those into 5 key barriers, so situational, psychological, interpersonal, structural, cultural. They might not mean a lot, but for example, it means that services aren't suitable for people with Lewy body dementia or Parkinson's disease dementia or young onset dementia. If you're 40 and have dementia or care for someone aged 40, you do not want to go to a bingo group for people that are older, for example. So really the suitability. Financially, it costs a lot to access care, so loads of barriers there as well. But also on a personal level, many people feel conflicted to access care. So there's these personal barriers as well. But you can read this systematic review. And just to follow on kind of the global angle, we're working with, we're leading a European task force called Interdem. So if you're familiar with Interdem, it's a fantastic network of European researchers, but we're also working with the European Working Group of people living with dementia and the European Group of caregivers. So what we've done so far to again compare how do our inequalities that we experience in the Northwest Coast and in England, how does that compare across the board in Europe? We've done a survey with academics, people with dementia and caregivers across 10 countries, and we found some key barriers that are very similar across all of our countries. So first of all, there's lack of information after diagnosis. If we don't receive the information once you get a diagnosis from your GP, where do you go? And we know that many people don't have an Admiral nurse or a link worker or care navigator to really navigate those services. We also found a lot of stigma, particularly in people from different cultural backgrounds, lack of care professional communication. Again, many people receive or get dumped on a lot of information at the first diagnosis, but then there's nothing else, and financial costs, etc. So lots more. We're also currently doing a systematic review on misdiagnosis on dementia. So just to kind of highlight, we're doing different angles of trying to understand what are the inequalities and how can we improve them. And specifically with this task force, we're working with Alzheimer's Europe as part of this, and they're linked in with MEPs, European Council, etc. So there's this policy link as well. And finally, because we don't just do research, we want to try and change something. We have received some funding last year to do a really fun, if I can say fun in dementia, public involvement activity. So we have co-designed, the prototypes will be delivered to my home any day, a dementia inequalities board game. So we've done all this research in the past few years, 5-6 years now, and we've set down different workshops, virtually and face-to-face, with people with dementia, carers, nurses, care providers, etc., third sector, to try and develop a game to understand, well, first of all, to inform people about those inequalities, but also to sit down together, old school board game, and have a chat about it. There's lots of different elements to this game. Hopefully at the next ARCFEST or so we can present it, but just to see here one of the full workshops, and it's really nice to see something from research come to an actual concept that you can hold, and it's a game, hopefully to educate people a little bit better. And that's me done. Thank you.
Thank you very much.